My name is Stephen Cook.
Okay.
And I'm an MD. I live in Chippewa Falls, Wisconsin. I was a family practice doc for 5 years and been an ER doc for the last 30. And I started coming down here about 20 years ago. I signed up for I wanted to do some mission work somewhere. And back then we didn't have internet and it was really hard to find opportunities. And I ended up bumping into at a booth at a ER convention, Christian Medical and Dental Society, and they had 2-week missions in a variety of places which fit my time schedule quite easily, and one of the places was Ecuador, and I had heard Ecuador was beautiful from a friend of mine's father did some medical work here when I was a kid, so I said, Ecuador. I brought my oldest son with me at the time, he was 14, and we went, and it was a very interesting experience. I was scared before I came because I didn't know what I'd see and what I'd need to know. And subsequent to that, then the people who interpreted for me are the people who have set up the hospital here in town, or the clinic here in town, and the foundation and a church in town. And they've continued to grow over the years, and we just have brought various groups. We've had as many as 29, I think, was the most people we've had in a group coming down. Most of the time we're somewhere in the mid-20s. This was 14, which is our smallest group that we've had in a while. We've generally done orthopedic and general surgery. The orthopedics, we will do a variety of things, but we have been fortunate enough to be able to connect with some of the hardware people. So we do between 4 and 8 total hips every trip, which is a pretty big operation for coming in. We get the small ones because the size of the hips down here are generally a little smaller than they are in the States, and so some of those may not be as frequently sold, I guess, but they let us have some of the small hips generously, and we install those in down here. We will do some other orthopedic procedures. We've done tendon releases and things for people who are kind of crippled up and don't have options for getting around. General surgery, we do hernias, gallbladders, variety of tumors, skin flaps and grafts, and take care of bed sores for people who have not had good care, so a whole gamut of things. We've done as many as 45 operations in a week. Usually most weeks we do somewhere around 25 to 30, somewhere in that range. We'll see a few hundred people in general clinic. We bring whatever meds and supplies we can down. Over the years we've brought a lot of stuff down here to do the work. Most of the tools that we have that we do the work with are things we brought down that hospitals up in our area have donated. So that's been useful, so we can keep reasonably up to date with equipment without them having to purchase it, and at the same time be able to do the procedures that have, we're trying to do stuff that'll have some impact. Obviously in general clinic the stuff I do will be somewhat limited much of the time. If I only have 2 weeks worth of asthma meds, they're maybe better for 2 weeks, and after that they're kind of back to wheezing again. But you try, and much of it is just people trying to get another opinion on something that they've been sort of told can't be fixed. And a lot of people have a lot of pain. A lot of people, the indigenous people here certainly do a lot of hard work. Now, I've looked at the basic care system here at times. I've been to the regional hospital, which is a frightening place.
Let me ask you a question about the hospital here. Are you working with private hospitals or public hospitals?
We have worked with a private hospital on a couple of occasions. Most of the time, the surgery we do is in a house that's converted to a clinic that has 2 state-of-the-art ORs that were built a number of years ago that are as good as any in the private hospitals down here. So we can really do pretty sophisticated stuff because we have clean ORs. We've brought down sterilizing gear and stuff over the years, and again, with the equipment we have, there's a number of things we can do. Scopings, we do scope surgery, so we're doing up-to-date kind of things. And we do a clinic when we first get in to just kind of screen to see what kind of stuff we're going to set up, and then every day we sort of fill the schedule up for the week. We usually only come for a week, and it's not that we couldn't do more work, but physicians, it's not as hard for a physician to get 2 weeks off. It's really hard for nurses to get 2 weeks off without blowing all their family vacation time. So if we hold it for a week, we find we get a lot more people willing to volunteer and want to come down than if we hold it for 2 weeks. So that schedule's worked out.
And this is the foundation that organizes the trip here?
Well, I organized the trip for coming down, and then we work with the foundation. So, you know, they certainly help on this end in terms of getting meals and help me arrange. We've stayed in this hotel for the last 20 years, so I love this place. This is just a cool spot. So, and you get to know a lot of people when you do this over a long period of time. You certainly make a lot of friends in terms of what's there. Yeah, the regional hospital, I've gone and toured that, and it was, when I went, that was the public hospital. My understanding was, at the time when we, probably around 2000, almost 60% of the advanced care in the country was done by charitable things, groups and stuff coming down. That so much of the country didn't have much care. Now their system has improved from what I understand, and they're trying to reach more people. I know they had these clinics we first went to, the very first time I came 20 years ago, there were clinics all over the country that they built, but they never had staffing for them. So they sat locked up, and they'd occasionally let the brigades use them, but not the gear in them. So they had brand new medical gear in them, locked in cabinets, and nobody ever used it. People would have gone 4 years and no one had touched it. So that kind of, where the infrastructure wasn't really there to sort of reach out and get regional things. So people travel a long ways to get care, it seems, you know, in terms of what I understand. Now, that percentage from 60% is down some now. There's more private hospitals that are there. And the private hospitals certainly have made themselves accessible to, you know, anybody who has the funds to pay for stuff. And it's still cheaper here to get stuff done than it is up in the States, so.
Yeah, that, one of the things that a lot of the Americans who I've talked to have said is that the care here is very inexpensive relative to stateside care. In fact, some people have been motivated to come here specifically because they have serious medical problems. And
medical tourism.
Home care and, or surgery or whatever.
Yep.
Now, have you encountered much of that? And what do you think of the quality of the care that they get?
There are certainly a lot of good docs that we have bumped into that volunteer time at the clinic and spend a lot of their time in private hospitals for their income, because the clinic is not supplying them with much in the way of income at all. So, and it's interesting, there is a little, even at the clinic, I think the quality, back to your original question, sorry, I don't want to get sidetracked. I think the quality has certainly been improving consistently throughout the years. And I think one thing you find in medicine, certainly I've seen in the States as well, quality attracts quality, because nobody does all stuff. And when you need to refer for all the other things that are outside of your range of specialty, if you don't find people there that fit the bill, it becomes uncomfortable in your practice in a lot of ways. And you really, that it behooves you to encourage and grow that network of people who can do other things, because it makes your job easier and better and the overall care better for your patients. So that does happen. You know, I don't deal with the private hospitals enough to know the numbers on anything, but I do know that, you know, for talking to the staff and the crew that work here, that there's a lot more of that. So.
You need to have a superior. Yeah. So I'm sorry. Go ahead.
No, it has been an interesting experience coming down here and seeing what's available and what changes over time, because you certainly catch up on all the things that, you know, seem to kind of happen. They did a good enough job, that this family I worked with, the Guidos, when we first started, that they were able to go from a single room in the back of the church that they used 2 afternoons a week to the city giving them a house, and then subsequently it's all expanded to the point where they have, you know, 4. And I've seen all that transition. The first OR we had a fireplace in, which I think all ORs would do better if they had that ambiance of a fireplace in your OR. But, you know, we could do a few simple things at first, and we never would have dreamed we could have done something like a total hip down here. And then now it's like, okay, what other stuff can we start to add? And you just need to know you have ongoing care so they know what's going on. Because antibiotics and cleanliness, not antibiotics necessarily, but cleanliness is something that's important. Antibiotics you can get anywhere, and certainly that's not a hard part, but trying to keep things clean from the start is the biggest problem in surgery, is to make sure you're starting clean. And we turn stuff down. There's lots of stuff that we can't do that still will have to be done locally. I mean, parts are, one of the hardest things is, if we bring down, example, 12 or 15 hips, we can only do those on people who those would fit. If they're too small, or they have some other reason why we do a alteration. In the States, you can find 600 different mechanical parts to adjust for that. Here, you can only bring what you can bring, and you can't anticipate that. So we're a little limited. Our orthopedic guys are really good at saying, here's what we can do, here's what we can't do. You know, and we have done people, the clinic charges people a little bit. They don't charge enough. They're not trying to make money off this. But what we found years ago, that when they first started, they didn't charge anybody at all. It was all, they did that. And what they found was if they didn't charge at all, people didn't follow up. They didn't value the care that they got. And when they charge, so they have a social worker that looks at stuff, and they may charge $2 for one person and $20 for another or whatever. But if they charge just enough that people say, okay, I'm paying a little bit for it, they'll follow up and they get invested in their care. And it's interesting because really, truly, if you look at how, I practice ER in the States, I can tell you the people when they come in, I never see the insurance. I don't know who has what, but I can almost guarantee I'm right 95% of the time to tell you who doesn't pay for their care. Just by the attitudes they'll have when they come in and how they deal with stuff. It's just a different attitude. And it's frustrating because you would think it'd be the opposite. The nice thing here is people here are so grateful for whatever care you give. And that's so refreshing when you come down, even when you're not doing a lot to help. But it's so refreshing having that attitude where you're really just connecting with patients. There's not an insurance in between. It's you taking care of them, and they're reciprocating back for the care.
So most of the people are not covered by any kind of state insurance?
No, they're not. I don't think they're seeing any insurance stuff over there.
Those are the people you treat, those?
Right. We treat the ones that are outside the insurance
more
pools.
needy,
Yep.
as far as care.
Yep.
One of the things that the insurance companies have claimed in their recent comments is that people of the same age are in better health, the Ecuadorians, than Americans are. Have you found that to be true in your experience? Or?
No. I would say that's probably not an accurate stat. I would say, there's health stats are unfortunately an easily manipulable stat. They talk about the being 38th or something in the world in healthcare, but it's so longevity. They don't take into account trauma, which accounts for the majority of American deaths. They don't take, that are premature in terms of drop in age out. They don't take into account a number of other factors. In cancers, for example, your survival rate's much better in the United States. Anybody who's wealthy from outside the United States and has cancers, many of them, if not most of them, come to the United States because you have access to all the various therapies that are out. Now, yeah, is care in the United States messed up in a lot of ways? You bet. Too expensive? Unbelievably. And most physicians don't even know what stuff costs, so stuff they order, there's a lot of ways the system could be fixed, without a doubt. But when you look at overall health, you're looking at what things you can do. Do we in the United States sometimes eat a little too richly and not do some of the things because it's there? Sure, okay, obviously. But I don't see people in the ER coming in every day who are saying everything hurts. It just, and there's not a patient I saw today that didn't have. We almost had shirts that said todo del cuerpo, todo del tiempo, because they say my whole body hurts all the time, and it's just, they're in pain, and their physical work that they have done and the amount of stress that they've suffered is huge. Now, are they alive at that age? Sure, okay. Is the quality of life something you can measure easily in a statistic and say, they're healthier? I don't know. One of the things they'll say is, okay, you have less heart attacks here. That'd be one of the stats. Well, understand that the statistics for heart attacks in the United States is garbage. Why? Because one of the ways they determine what stats cause things is by death certificates, a big way. On a death certificate, you're not allowed to put old age, I don't know, hey, they were old and they just died. You can't put any of those things. You have to put something down. What do 99% of doctors write? Heart disease. Because no one will challenge them on it. Now, did they do an autopsy and prove it was heart disease? No. Most of them don't necessarily have that kills them, but that's what they put as a stat. So they say, heart disease in the United States is this number, when the real number is a guess, but it's certainly way smaller because we're falling victims to a system, not necessarily accurate information. And we keep more records than other countries, And we have neonatal ICUs, better records, so that we keep stats of all the other countries, lose all those stats and sweep under the rug and then say, see, this is what we have. And it's apples and oranges. It's just one of those. So I'm not sure. I'm sure everywhere. And the other thing with medical care is everything filters, and you see that down here as well. The specialists we work with, the stuff we learned 10 years ago, they may have learned 5 years ago. Some of the stuff is just a little slower to filter down here. And that makes sense. You know, if the expense of the technology and the availability of the technology will be something that filters down as it becomes, anything you introduced initially is more expensive than it is a few years later when there's competition. So if the pool does it that way, you'll see just a little bit slower, but it's there. I mean, it comes, it just is a little slower to filter. And I guarantee in the private hospitals, in these physicians, if they're getting medical people coming in for that, if they're getting people who are paying and coming in for it, they're going to be up to date. There's an incentive for them to be up to date because their life will be enriched by it, as well as taking care of the people they're taking care of. There's certainly medicine everywhere you look that has had even in the socialized systems where they've really had the government pays for it, there's always an underground black market system of stuff happening. And in those systems, the people who are surfacing those people do well because there's a need. And if people have any funds, they'll find, there's a need, it gets done. So. Truly.
One of the things that I mentioned yesterday was that they're considering the health insurance companies in Ecuador are considering not being available to American expatriates because they say that Americans just demand a lot more, they use a lot more medicine, they expect a lot more attention as compared to their Ecuadorian clients. I know you're not familiar with that, but do you have any thoughts about that?
What I would guess would happen is that will be more a problem for the internal medicine and generalists first, and the surgeons much later. Because I'll bet they're not using a lot more surgical procedures, and if they are, I'll bet those are recompensated enough that those physicians don't mind that. In internal medicine, if you're seeing somebody frequently and you're not getting results with it, sometimes there's a tendency to say, I don't want to see that person. I've already seen them 3 times this month. Oh my gosh, are they here again? Partly because you don't have a solution for them. And some of it also truly here, most people are not on more than 2 or 3 or 4 meds at the most, if that. And I see people on 15 or 16 all the time. We way over-medicate in the United States. I truly believe if we took everybody off medications, 75% of people would do better than they would do now. And yeah, some are necessary. I'm not saying all meds are bad by any means, but we so over-medicate, it's just bad. It's just not the way medicine needs to be. And I suspect they're not used to dealing with that, so that's a bit of a frustration. But it probably is going to be more with the primary care internal medicine than it will be with the surgeons. And so whether that'll start translating down if they're skillful. The other problem is, culturally, there's such a difference. And I need to be aware when I'm taking care of people here how they culturally look at medicine and things, so if I'm giving them advice, I can do it in a way that I don't ever want to badmouth their physicians. But I want to make sure if their physician told them to do something that I believe these evidence says don't do it that way, that I will present it in a way that tries not to denigrate their physician, but gets the patient to do what I want them to do. And I'll say things like, oh, your doctor was right, that used to be what we thought was true, but the newest evidence says, and then they won't hold it against him because they think here he may not hear all the newest evidence. So you can find ways to do that. But culturally, for a physician here to deal with somebody from the United States who's on 15 meds or may have had a lot of stuff, could probably be very tough. Although I'll guarantee they have patients here who they also deal with and they don't want to see that they've seen a million times. I'm sure that happens. So people are people everywhere.
I have 2 more questions for you. One was about the training that you think the Ecuadorian doctors have had. Have a lot of them been trained in the States or in Cuba? Or?
Many of them will have had training elsewhere. The orthopedic guy I know had training in Mexico and in France. There's a general surgeon I know who had training in Cuba. There's a eye doctor who had training in the States. So a lot of them do get they may get some of the base training, but they certainly do the training program, and you see that truly with the rest of the world. I mean, right now in the United States, go through any of the residency programs and look how many of the people there are foreign. There's an incredible number. And the initial thought with that was, great, we train people that can go back to their countries and they do stuff. But what's happened is like 75% of them stay in the United States, and why wouldn't you? I mean, I understand that if you've got a good job and you like it there, you'd stay where you want to be. But there are a lot of people who train elsewhere to get experience. Now, will some of the people who have trained elsewhere go into education and train people here? Because that's the way the system changes, is the people who have the expertise stay and start training locally. That'll be the challenge for them. And whether they recruit that, whether there's any system in place for the people who are the health ministers and stuff to look at saying, we have to make this be a priority and make it valuable for these people to want to stay here and do that. Time will tell us. But that's how that system changes. But yeah, many of them get training elsewhere for sure, from around the world, absolutely.
And finally, do you want to make a plug or suggest how people might be able to help your program, the kind of thing you're doing,
Well, my plug would be this. In your heart, you want to do something to help other people. Everybody feels that. God put that in our hearts. I truly believe that to be the case. And just find an opportunity. Most people just don't make the effort to find the opportunity. Here is wonderful. There's a jillion wonderful places around the world. Go do it. You do it once, you will feel so much better for it. It is. I do this, and people at home say, "Oh gosh, you're so nice to do this." And I tell them, "No, I do this selfishly. I do this because this is for me. I do this because I get a lot out of it." And you will. It is those things that fulfill your life, that make your life better. So I would tell everybody to do that. I mean, anywhere you go. This is a great opportunity. You know, certainly I'm not set up to organize it from large numbers, but hey, if people ever want to contact me and interested in going, beachdoc@charter.net is my email.
What is it?
BEACHDOC, beachdoc at charter.net. Give me an email, I'll throw you on the list, and if you're interested in going, when I come down, I send emails out to everybody when the first is, and whoever signs up, we go. So.